name is Tess Taylor, and I'm a community education specialist at MDA. We're thrilled to have you join us for today's webinar, Cardiac Care for LGMD. This learning event is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events, including a live Q&A for LGMD Awareness Day on September 30th, 2024 at 4 p.m. Eastern Time. Our live Q&A will feature today's presenter, Dr. Kamdar, as well as other neuromuscular professionals who can answer your questions regarding LGMD. For more information and to view other recent and upcoming LGMD webinars, please click on the link in the description box below. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. Now, it is my pleasure to introduce today's speaker, Dr. Kamdar. Dr. Kamdar is a cardiologist who treats advanced heart failure. She practices primarily at M Health Fairview Clinics and Surgery Center Heart Care. She also sees patients at the M Health Fairview University of Minnesota Medical Center and M Health Fairview Southdale Hospital. Her clinical interests include muscular dystrophy-related heart failure, inherited cardiomyopathies, heart transplantation, and mechanical circulatory support. Dr. Kamdar is an assistant professor of medicine at the cardiovascular division of the Department of Medicine at the University of Minnesota. Her research interests include cardiac transplantation outcomes in patients with neuromuscular associated cardiomyopathies. Dr. Kamdar, thank you so much for being here today. I'll go ahead and stop sharing my screen so you can share your slides.
Well, Tess, thank you for that wonderful introduction. It's really a pleasure to be here today and being able to speak to patients and their families who are living with neuromuscular disorders such as limb-girdle muscular dystrophy. I think it's such an important aspect of the care for patients to be able to disseminate this knowledge in a broad way. So I'm going to, as Tess mentioned, I am an advanced heart failure and transplant cardiologist, and my main interest from a cardiovascular perspective is muscular dystrophy-associated cardiomyopathy. I have no disclosures other than I'm an MDA grant recipient. And so over the next 45 minutes or so, I'm going to talk a little bit about an area I'm really passionate about, which is muscular dystrophy cardiomyopathy, and specifically limb-girdle cardiac care. Talk a little bit about limb-girdle muscular dystrophy. You'll get more of this with Dr. Kang. And then how limb-girdle muscular dystrophy is not only a skeletal muscle disease. We'll talk about how the heart can be involved in limb-girdle muscular dystrophy, what the current guidelines recommend for cardiac care, the current treatments, including medical therapies, device therapies, and advanced heart failure therapies. And then, what are the efforts for research that provide limb-girdle muscular dystrophy patients and their families hope. So a brief overview. So again, I'm not a neurologist, but there are over 30 subtypes of limb-girdle muscular dystrophies. And limb-girdle muscular dystrophies are the fourth most common cause of genetic muscle weakness. It affects approximately 2 out of 100,000 individuals worldwide and affects both men and women equally. And amongst this group, the mutations that result in the changes that are seen in the muscle impact how the muscle cells function. And this results in weakness in the hips and shoulders. The onset of symptoms is variable, and cardiac and respiratory involvement can occur, which is what we'll be talking about, the cardiac involvement in muscular dystrophies, and specifically in limb-girdle. So to start with, in 2018, the limb-girdle muscular dystrophies are reclassified, and it's really based on the type of genetic mutation. So autosomal dominant means that one of the two genes has a change, and having one gene change results in the disease. And so this is approximately 10% of the limb-girdle muscular dystrophies. These are some of the muscular dystrophies here, limb-girdle phenotypes that have these specific types of mutations, and that can result in cardiac dysfunction as well. And then about 90% of the limb-girdle muscular dystrophies are what's called autosomal recessive. That means both of the gene copies of that gene need to have the mutation to result in the muscular dystrophies. And so these are a large list of these. These have really expanded and being able to identify which type it is based on genetic testing that's further been developed in the last 10 to 15 years. And so, I've highlighted again some of the muscular dystrophies that have cardiac involvement here. But really, what I would like to emphasize is limb-girdle muscular dystrophy is not only a skeletal muscle disease, but often a cardiac disease as well. And so, as you can see here in limb-girdle muscular dystrophy, there are a variety of genes that are changed that result in a change in the protein in muscle cells, and those are what result in the weakness. They affect the ability of the muscle cell to retain its strength, and with weakness, that's what causes the loss of that causes the weakness. But these same genes and proteins are actually also located in the heart. And so you can see here with the sarcoglycans, dysferlin, caveolin, as well as the fructin proteins, lamin A and lamin C mutations, and then TRIM32, multiple of these proteins and genes are also located in the heart. And so neuromuscular disorders often involve the heart. They're increasingly being identified to have cardiac involvement, and cardiac involvement includes heart failure or cardiomyopathies, abnormal heart rhythms, and changes in the way that the heart conducts electricity. Cardiovascular involvement in any of the muscular dystrophies impacts the patient and their families because the patients develop symptoms and it can worsen the overall survival as well. But there's hope. We're doing more and more to understand how muscular dystrophies affect the heart. Here again, I've just highlighted some of the limb-girdle muscular dystrophies that have heart involvement, and there's a number of other muscular dystrophies which are listed above, including the dystrophinopathies, including Becker and Duchenne muscular dystrophies and myotonic dystrophies, which have a higher likelihood of cardiac involvement. So again, to emphasize the cardiac involvement in limb-girdle muscular dystrophy, there are abnormal heart rhythms, which are also known as arrhythmias, and then heart muscle weakness or heart failure, which we refer to as cardiomyopathy. So I will be using some of these interchangeably. And then some of the limb-girdle muscular dystrophies have no heart involvement, but it's important for us to be able to understand what they are. So in the development of heart failure, how does this occur in limb-girdle muscular dystrophy? So we know that many patients start with a normal heart. Over time, there's a little bit of scar tissue that can occur, and we can see this by cardiac MRI. Initially, we were seeing this at the time of autopsy, but now with cardiac MRI, we can actually see this non-invasively. And then over time, as scar tissue, similar to muscle, replaces heart muscle tissue, it results in progressive weakness and then can result in end-stage heart failure. This is the scar tissue I was mentioning that can be seen on MRI. So the black areas, this is the left ventricle. The black area is normal heart tissue where there's no scar, where there's areas of white, which you can see here with the arrows are more clearly here. That's where scar tissue has replaced the normal heart muscle, and which is what we can see in a variety of muscular dystrophies, including limb-girdle muscular dystrophy. And so with heart failure, it's important for patients living with limb-girdle muscular dystrophies and their families to recognize what the symptoms are. And these symptoms include shortness of breath with activity, swelling of the legs or abdomen, being able to do less activity than usual. So a sudden change or progressive change, and you're able to walk a certain distance that slowly gets less and having more symptoms, lightheadedness, waking up at night with shortness of breath when laying down, skipped beats, missed beats are all signs of heart failure. Some of the challenges of diagnosing the symptoms of heart failure in limb-girdle muscular dystrophy are also related to the muscle weakness that occurs, and sometimes trying to tease out, is it coming from the muscular dystrophy or is it heart failure? But there are ways that we can identify this, which I'll go through. So another aspect is abnormal heart rhythms or arrhythmias are also common in muscular dystrophies. So limb-girdle muscular dystrophies, based on the literature, have various atrial or ventricular arrhythmia, so coming from the top chamber of the heart, or atrial, ventricular coming from the bottom chamber of the heart, and conduction delays, which are a delay or change in the way electricity goes throughout the heart. And this varies by the different types or subtypes of limb-girdle muscular dystrophies. It can really vary from patient to patient. Symptoms that patients living with limb-girdle muscular dystrophy and their families should be aware of include palpitations, feeling like their beats that are skipped, racing heart, missed beats, feeling like you might pass out or actually passing out. If you do pass out, it's a medical emergency. You should call 911 and go to the emergency room to ensure that you can be evaluated to see if there are abnormal heart rhythms that are precipitating the symptoms. And then just, very briefly, this looks like chicken scratch, but as cardiologists, we're always looking at this, looking at different types of rhythms. So normal rhythms, this is atrial fibrillation, which is a fast rhythm that comes from the top chambers of the heart and is irregular. And then ventricular tachycardia, this is coming from the bottom chambers of the heart, also a very fast rhythm. These are rhythms that can cause you to pass out and lose consciousness and can be quite dangerous. So these are the reasons to be able to identify that for patients as well as their families to be able to identify the symptoms to get appropriate help. So, how do we care for the heart for patients who are living with limb-girdle muscular dystrophies? So in 2017, the American Heart Association came out with guidelines for patients who are living with muscular dystrophies to understand cardiovascular or heart care. And so one of the main aspects that this document highlights is that neurologists who are diagnosing and managing neuromuscular disorders should identify a cardiologist with an expertise in muscular dystrophies, or at least identify a heart failure cardiologist or heart rhythm specialist, such as an electrophysiologist, to manage the specific issues related to these muscular dystrophies. And so, overall, there are some subtypes of the limb-girdle muscular dystrophies, such as the ones that are listed here, that have a higher likelihood of cardiac involvement, which I had highlighted earlier. More importantly, the proactive cardiac care, which includes screening at the time of diagnosis and subsequent follow-up, is really critical. And patients with limb-girdle muscular dystrophy should undergo cardiac evaluation at the time of diagnosis and then subsequent follow-up after that, which I'm going to highlight. And those patients who have heart failure should be followed up more frequently. And then symptoms that, especially those with symptoms, including palpitations, should have additional screening. And I'm going to summarize this here. So really, what does the heart care in patients with limb-girdle muscular dystrophy entail? So all patients with limb-girdle muscular dystrophy should be screened for cardiovascular involvement at the time of their diagnosis. This cardiovascular screening includes a cardiac history and exam, an electrocardiogram, cardiac imaging, either by echo or MRI, and then ambulatory telemetry monitoring. And this in the guidelines is, a possibility based on symptoms. And I'll talk about a little bit further about what we also do. So if you undergo cardiovascular screening and there's no evidence of cardiovascular involvement based on the exam, the testing, the current guidelines recommend following up in 2 years. If there's positive cardiac screening, it's recommended that you should be seeing a cardiologist annually. However, if you have symptoms, for example, of heart failure or arrhythmias, should have treatment for these aspects and then also have more frequent follow-up. So these provide the overall kind of outline of how patients with limb-girdle muscular dystrophy should receive heart care. I think really again, to emphasize is that it's important to have screening. More and more, we're recognizing that there's heart involvement and that in patients with muscular dystrophies, including limb-girdle muscular dystrophies, and being able to identify it early is important. And this is where I think there's hope for patients as well as their families, is that there are ways that these can be treated, which I'm going to go through, that can reduce the likelihood of progressing to more severe heart failure or abnormal rhythms. So, when you go to the cardiologist, what are these different tests that we've recommended? So first, for cardiovascular the cardiovascular exam, they'll include the cardiologist talking to you about what are different symptoms that you have. That'll be, how far can you walk? What are activities that you do? Do you get short of breath? Do you have symptoms? Has your weight changed in terms of weight gain or fluid retention? So those are some of the main questions they'll ask. Talk about your family and family history of other heart involvement, whether you have aspects such as diabetes, high blood pressure, high cholesterol, history of smoking, or family history of heart disease. Those are all important for us to be, as cardiologists, to understand how the heart may be involved. One of the tests that would be done in the office and is recommended is what's called an electrocardiogram or an ECG. During the ECG, the medical assistant or technician will attach 12 leads across the chest, including on the legs, the arm, throughout the chest. What we get is an immediate readout, which is the electrocardiogram, again, the chicken scratch that we cardiologists like. And this actually tells us how the heart rhythm electrical activity is happening at that very moment. And as cardiologists, what we're looking for are there changes in the way the electrocardiogram looks like. This is a normal electrocardiogram. Are there changes in the way that this spacing occurs, irregularity in the spacing, changes in the length of certain aspects? And so that's what your cardiologist will be looking at. The next we talked about cardiovascular screening is ambulatory telemetry monitoring. So in the previous slide, we talked about electrocardiograms. The ECG gives us a snapshot at that very time. However, abnormal heart rhythms, skip beats, missed beats, these can happen at a variable interval, and patients don't have them in the few seconds that we're grabbing the ECG. So ambulatory telemetry monitoring can include Holter monitoring or more simple patches, such as a Zio patch, in which electrodes, in this case in the Holter monitor, multiple electrodes are attached to the chest, and there's a little monitor that continues to read out and gives you a continuous ECG versus a little patch in which you can then, if you have symptoms, for example, a skip beat, missed beat, racing heart, you can click that button and that tells the cardiologist who's reading these that, hey, this was a symptom that occurred during this time, and helps us to hone in if that is in fact an arrhythmia. The current guidelines recommend to do the screening only if there are symptoms. However, not everyone always has symptoms when there's abnormal rhythms. And so I feel like this is a very important test. These monitors can be worn, from a short period of time for 2 days up to 14 days. We would typically recommend the 7 days because then we can capture more. If there's any abnormal rhythms, we have a longer time of capturing these. If the abnormal rhythms or palpitations, skip beats, missed beats are less frequent than every 2 weeks, there are other types of monitors, including event monitors and loop recorders, which can be utilized to get a longer readout of the rhythms over that time. And those are typically would be recommended by your cardiologist based on the initial testing and exam. So the next aspect, we talked about heart rhythm involvement in limb-girdle muscular dystrophies, but the next part is the actual heart muscle. Similar to skeletal muscle, cardiac muscle can also be involved. So there's 2 types of heart rhythm or heart screening imaging tests. The first is the echocardiogram. So this is a heart ultrasound. Again, these are non-invasive and not painful. These are done in the cardiac clinic or in the hospital, where in the heart ultrasound, an ultrasound probe is used to look at the heart through putting sound waves through. And that shows us pictures of the heart. And this is kind of this blurry picture shows, here's the left side of the heart muscle, the bottom chamber. And that can tell us the advantages of the echocardiogram is it shows us about the heart muscle function and can tell us if there's any changes in the heart valves. And so that's the important, these are tests that take 30 to 40 minutes and can be done in the clinic or in the hospital, depending on where it's done. And also, again, not painful. Cardiac MRI provides us similar aspects to the echocardiogram, including heart muscle function, but it actually provides us some additional information. It can give us better images to see what the heart looks like. So you can see here in the image on the right that this is the left side of the heart muscle. The heart muscle shows up as black. A contrast dye called gadolinium or gadavis is also used at the time of the MRI, and where there are areas of scar tissue, this particular dye goes in, and that shows up as white. And as we talked about earlier, scar tissue formation in the heart is actually one of the earliest signs of heart involvement. And identifying that early is important because there are ways to treat the heart muscle involvement at an early stage to reduce the likelihood that the heart muscle fibrosis or scar tissue can progress to further heart failure. So that's why we feel that cardiac MRI, if possible, is a good option to be able to see about scar tissue, especially at the initial time of diagnosis. Again, cardiac MRI can be a bit more expensive. It's not always available immediately in all clinics or hospitals. And then if patients have implanted metal devices, it's important for them to have screening to know if they can undergo cardiac MRI. So those are some of the limitations. But we feel that overall, if it's feasible to do an MRI, it provides a significant amount of information that is of benefit to the patient. So, we talked a little bit about what the progression of heart dysfunction and heart muscle dysfunction occurs in limb-girdle muscular dystrophy, and going from normal heart, and in cases where heart involvement does occur in patients with limb-girdle muscular dystrophy, the first sign again is muscle fibrosis, where scar tissue forms. As more scar tissue forms, it can replace the normal heart muscle tissue, resulting in end-stage heart failure. The more scar tissue there is, the more abnormal heart rhythms can also occur. So really identifying it at these early stages is important. One of the other aspects is if there is significant heart failure, how can we try to move this back to an earlier stage of heart failure where there isn't significant muscle dysfunction? And that's where the medical management of the limb-girdle muscular dystrophy heart failure is important. So there are 4 main therapies for heart failure that are used. That includes ACE inhibitors like lisinopril, angiotensin receptor blockers, which are medications like valsartan, losartan, angiotensin receptor neprilysin inhibitors, which are medications like Entresto or sacubitril valsartan, beta blockers, which are metoprolol, carvedilol, bisoprolol. They're typically ones that are used in heart failure, mineralocorticoid receptor antagonists. These are medications such as spironolactone and eplerenone, and then SGLT2 inhibitors, which are medications that were initially developed for diabetes, but are now used to have significant evidence in heart failure. These combination of these 4 medications help reverse the heart dysfunction and can improve survival and quality of life. And just to show you, so these are this is the landscape of heart failure therapies that are overall used in all types of heart failure. There are a number of trials, as you can see here. And really, these are the 4 pillars of heart failure because these are the ones that in about 2/3 of patients can actually reverse heart failure and improve the heart function or completely normalize heart function. And so they also decrease the risk of death due to heart failure as well and reduce symptoms. And those are the important aspects when there's heart failure. And I think that's what, even if as a patient you have heart failure, there are medications that can reverse heart failure or reduce the chance that the heart failure progresses and reduce the chance of significant adverse outcomes related to heart failure. So some of the challenges of medical management in limb-girdle cardiac involvement, including heart failure, is that patients with limb-girdle heart failure were not included in the majority of the heart failure trials. There's also a significant heterogeneity or difference based on different subtypes, and even within the same subtypes, different patients can have different heart involvement. So we don't know how that impacts the heart. And then there's really no cardiovascular trials that are specific to patients with limb-girdle muscular dystrophy. However, based on the very strong evidence that we have in other types of heart failure, that we feel that if patients with limb-girdle muscular dystrophy have heart failure, that they should be treated like any other heart failure patient as much as possible. And so, some of the areas where there's gaps in the cardiovascular care comes from other parts of the literature. So this is work that we did using the MDA US Neuromuscular Registry, where we looked at patients with Duchenne muscular dystrophy who have a high incidence of developing heart failure. And what we identified is that some of these 4 pillars of medications used for heart failure, for example, beta blockers, which we use for patients with heart failure, we actually identified that the majority of the patients are not being treated with either a standard beta blocker or heart failure specific beta blocker. And so these are areas where there's clinical gaps, and it's important to be able to identify these so that we can improve care for patients. Similarly, in device therapy, so we talked about abnormal heart rhythm dysfunction, and now moving to the aspect of abnormal heart rhythm and heart conduction. So if there are conduction system delays that are identified either on the ECG or on the ambulatory telemetry monitoring, or they're abnormal rhythms, patients should see a rhythm specialist. So I think about the heart like a house. The walls are the heart muscle. The electrical system is what the electrophysiologists deal with. And then we have the plumbing, which are the heart blood vessels. And so the electrophysiologist or the heart rhythm specialist should be seen. We work with specific heart rhythm specialists who have a real understanding of muscular dystrophy related abnormal rhythms. Pacemakers, ablation, or defibrillators may be recommended by the heart rhythm specialist based on the guidelines that exist in the heart rhythm world. If the ejection fraction in patients who have heart failure related to their limb-girdle muscular dystrophy remains less than 35%, an implantable defibrillator may be recommended because there's a higher risk of abnormal rhythms, and a defibrillator provides an insurance policy against abnormal rhythms that could cause sudden cardiac death. And then in limb-girdle muscular dystrophy 1B, which is the lamin A related mutations, an ICD may be recommended earlier due to the high risk of abnormal rhythms. So another aspect of, again, clinical gaps in the care for patients with neuromuscular disorders. So in looking again at the US Neuromuscular Registry from the Muscular Dystrophy Association, the majority of the patients, again, here, this was Becker and Duchenne muscular dystrophy, we're actually not seeing cardiologists. And so again, this emphasizes the need that for patients who have muscular dystrophies, including limb-girdle muscular dystrophies, to be seen by cardiologists and for us to close this gap. So how we've done this, so we've integrated this data, and at the University of Minnesota, we developed a neuromuscular cardiomyopathy clinic. And so this is, in conjunction with our neuromuscular neurologists, genetic counselors, pediatric cardiologists, adult cardiologists like myself and Dr. Gary, as well as our pulmonologists, heart rhythm specialists. So we started this in 2014, and then this is multidisciplinary, as I emphasize. We do cardiovascular screening in all neuromuscular disorders, including limb-girdle, and then treat the cardiomyopathy or heart muscle dysfunction in neuromuscular disorders, including limb-girdle, and including advanced heart failure therapies such as heart transplantation and ventricular assist devices. And we also have a registry to further look at this. So, our protocol differs slightly. We agree with the guidelines that all patients with limb-girdle muscular dystrophy should be seen by a cardiologist and evaluated for heart involvement. And so in our neuromuscular cardiomyopathy clinic, patients with limb-girdle muscular dystrophy are seen on the same day as their neuromuscular neurologist. We have clinic at the same time in adjacent rooms. They also see pulmonology if necessary, physical therapy if also necessary. We do lab testing, including cardiac biomarkers, which include N-terminal proBNP, high sensitivity troponin, cardiac MRI, electrocardiograms, and ambulatory telemetry monitoring. And vitals are obtained on all patients. If the ejection fraction is normal, but there's scar tissue, we utilize angiotensin receptor blockers and mineralocorticoid receptor antagonists are started because these have some evidence that they may help with the scar tissue formation. If there are abnormal rhythms or conduction system delays, we have patients see our specific heart rhythm doctor to see these patients to address those. We typically see patients annually if there's no significant cardiac involvement, or sooner if there is. And as I mentioned, if patients have heart failure or abnormal rhythms, we do see them more frequently depending on their need. And so this is our protocol. We really, again, screening at the same time of diagnosis. We do cardiac history and exam, electrocardiogram. Our preference is for cardiac MRI, as I mentioned, because it provides additional information if there's scar tissue, and we do ambulatory telemetry monitoring at the time of diagnosis. Typically, if there's negative cardiac screening, we would recommend that when patients see their neuromuscular neurologist annually, that we would also see the patient. There may be less testing that's necessary at that time, but just again, because things can change from year to year, to be able to identify that. If there is positive cardiac screening, for example, fibrosis on cardiac MRI, we would start medical therapies, may see these patients more frequently. If there are abnormal heart rhythms that are asymptomatic, we have the patient see a heart rhythm specialist. However, if there's heart failure, we see these patients, we treat them and see them more frequently for heart failure, and then consideration for heart failure advanced therapies, as well as heart rhythm management. And so talking a little bit, I'm an advanced heart failure cardiologist, and so one of the aspects that we see is significant heart failure. And so patients with neuromuscular cardiomyopathy can progress to advanced heart failure. However, advanced heart failure therapies, such as heart transplantation or heart pumps, which are called left ventricular assist devices or LVADs, are often underutilized in this patient population. There's also relatively little data outside of case reports on the referrals or outcomes of advanced heart failure therapies or ventricular assist devices and heart transplantation in neuromuscular cardiomyopathy, including those patients with limb-girdle muscular dystrophies. So we've looked at the International Society for Heart and Lung Transplant to understand what are the outcomes in terms of survival in patients who have muscular dystrophies, including limb-girdle muscular dystrophies, as opposed to other types of heart failures, similar, that are not muscular dystrophy, but not due to blocked arteries. And so what we showed here is that in a group of over 80 patients, the one in the dot line are those patients with muscular dystrophy related heart failure who underwent heart transplantation. And in the solid line are those with non-muscular dystrophy heart failure who underwent transplantation. What we showed is that there's no significant difference in the survival, which means that patients with select group of patients who underwent heart transplantation due to muscular dystrophy had similar survival outcomes as compared to those patients without muscular dystrophy. And so this is important that the survival is similar, and that should patients with neuromuscular disorders like limb-girdle muscular dystrophy be considered for heart transplant. And so this is some of the research that we're doing, sponsored through the Muscular Dystrophy Association. And so we're looking at what is the outcome of ventricular assist therapy as well as cardiac transplantation in patients with muscular dystrophies. We have multi-center, there's 5 different centers as well through the MDA, and then multiple other centers that do heart transplant and LVAD in patients with neuromuscular disorders. And this will allow us to understand what outcomes are and how we can optimize the care for neuromuscular patients who have advanced heart failure. And really, what I'd like to emphasize is that the interdisciplinary care is really needed for limb-girdle muscular dystrophy, especially for the heart care. So strong collaboration between neuromuscular neurology and cardiology, as well as the pulmonologist for lung management, nutrition, physical medicine, and rehab. But all of these pieces need to be, limb-girdle muscular dystrophy has multiple involvement, and really being able to have specialists and individuals who are addressing each part of the puzzle is necessary to be able to optimize the care for patients with limb-girdle muscular dystrophy. And so, to briefly talk about emerging therapies in limb-girdle muscular dystrophy, so there are gene therapies that are being developed to replace the gene mutations, the abnormal protein, through replacing the gene in these muscular dystrophies. Again, and then, for example, our lab and other labs are using stem cells that are derived from patients that retain their specific mutation, and then developing these patient-specific heart cells, patient-specific stem cells into heart cells. And then we can actually study the heart cells of that specific patient in the dish to understand what are the potential cardiac involvement. These are all early research stages, but I think this really provides hope to patients who are living with muscular dystrophies and their families, that there are labs and companies working on developing new therapies that will hopefully mitigate limb-girdle muscular dystrophy and the heart involvement. And to summarize, cardiac involvement occurs in patients who are living with limb-girdle muscular dystrophy. This includes heart muscle weakness, which is heart failure, or abnormal heart rhythms or arrhythmias, certain subtypes of limb-girdle muscular dystrophies have an increased risk of cardiac involvement. Cardiovascular screening should be done in all patients who are living with limb-girdle muscular dystrophy, should involve an ECG and cardiac imaging. Regular cardiac follow-up is necessary because the heart involvement can change over time. And that limb-girdle muscular dystrophy patients with heart failure should be treated with appropriate heart failure therapies. And those with arrhythmias or conduction system delays should be considered for appropriate device therapy based on the recommendation of the heart rhythm specialist, and that family members of affected patients should also be screened. I'd like to acknowledge the Neuromuscular Cardiomyopathy Program, as well as my funding sources, including the MDA, and really appreciate this opportunity to be able to talk to you about a little bit about the area that I'm particularly passionate about. I'm glad to take any questions. Thank you.
Thank you, Dr. Kamdar, for your great presentation. I appreciate all the great information, and we'll definitely have our Q&A session on September 30th. And so anyone who's watching today, if you can join us on September 30th and get your questions answered by Dr. Kamdar. So thank you so much.
Absolutely.
So let me just get resituated here. If you are new to MDA and have been diagnosed with a neuromuscular disease under MDA's umbrella, or if you are a loved one of someone who is diagnosed, we encourage you to stay engaged with us here at MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. MDA's community education team would like to invite you to our upcoming in-person and virtual events. We are always adding more opportunities to learn with us, so use the QR code on your screen or check in the description box below to get involved with the MDA community. If you're watching this from the future, not to worry, all of our virtual learning programs are available for on-demand viewing, and live education opportunities are updated regularly at mda.org. You can learn more about these events by visiting our website. MDA will be hosting 4 in-person symposiums across the country. Join us for these half-day multi-session programs with both disease-specific learning and general learning sessions that are applicable to neuromuscular diseases of all kinds. As always, these events are free to the MDA community. We would love to hear your questions and comments about today's webinar. Please feel free to contact MDA's Resource Center at 1-833-ASK-MDA1 or email the Resource Center at resourcecenter@mdausa.org, and we will be sure to get back to you. Thank you again to Dr. Kamdar for joining us. This concludes today's webinar, and we will see you on September 30th. Bye.